Hey everyone, welcome to All You Need to Know. This is our series where we discuss high-yield, clinically relevant topics in short 8 to 10 minute long videos. Today we're going to be talking about hyperkalemia. So here's the first thing you need to know about hyperkalemia. Is it real? You don't want to act on a spurious lab, and when our cross-cover team at night gets paged about a potassium of 5.9, what's the first thing they do? They make sure they're not dealing with pseudohyperkalemia, right? So diagnosing pseudohyperkalemia is pretty easy since PowerChart will tell you when that's the case, but let's review why that happens. So pseudohyperkalemia is usually caused by the hemolysis of cells. So you can see here that potassium is largely an intracellular ion. So somewhere around 98% of all potassium is located intracellularly. So you can see in this cartoon here, all the potassium that's inside the cell and a relative small amount that's located extracellularly. And if you look at the concentrations listed here, these extracellular concentrations should make sense because this is essentially what we're measuring on a BNP. And here are the intracellular values, and you can see that for potassium, there's a magnitude of difference between what's located intracellularly compared to our extracellular potassium. Okay? Now, most commonly, hemolysis is due to a bad blood draw, and we're referring specifically to red blood cells. But there are situations in which you may have severe thrombocytosis or leukocytosis, and in those abnormal situations, those cells tend to be a little bit more fragile and can occasionally hemolyze as well. So sometimes you see it with other cell lines, but generally we're talking about the hemolysis of red blood cells that lead to a false elevation of potassium. So once you confirm that there's no hemolysis and that your hyperkalemia is for real and your potassium really is 6.2, what's your next step? Well, the first thing that I do is to grab an EKG, which is going to help me determine the urgency on which I need to act. And as everybody knows, we're looking for peak T waves. So let's talk about T waves for a minute. So this is an actual picture of me of when I was an intern using a magnifying glass and a slide rule, trying to make sure I'm not missing some peak T waves for that potassium of 5.1. Well, since I don't want you to have to carry a magnifying glass in your white coat, let me let you in on a couple of secrets about peak T waves. So first of all, generally they're not going to be subtle. Okay, so they should jump off the page when you're glancing at the EKG. The other thing about peak T waves is while they're very specific, they are not very sensitive for hyperkalemia. In fact, 40% of patients with potassium levels between 7 and 9 will have no EKG changes at all. And only about half of patients who code due to hyperkalemic-induced malignant arrhythmia will have an EKG change prior to the event. So while I think we probably way overtreat mild and even moderate hyperkalemia, the old adage that you probably shouldn't treat hyperkalemia until you see EKG changes should probably be given the old Yeller treatment. All right, so let's talk about causes of hyperkalemia. There's kind of three big categories. So you can either have too much potassium intake, and that can occur with food, TPN, certain medications, certain IV fluid formulations, and then packed red cells also contain quite a bit of potassium. The other mechanism by which we that results in hyperkalemia is inappropriate or often pathological transcellular shifts. So we see this with rhabdo. As I mentioned, we also see it with hemolysis, and then medications can do this as well. And then most commonly on the hospital medicine service, the etiology of hyperkalemia is going to be due to impaired excretion. So this happens with AKI, it happens with CKD, it happens with aldosterone antagonism, and it happens when you have RAS inhibition. That can be pathologic, or more commonly, it's going to be due to medication, specifically ACE inhibitors or ARBs. Okay, so when it comes to management, there are a couple of things that we need to consider. The urgency, the timing of intervention, and specifically I'm referring to how quickly a particular medication will result in lowering of the potassium, the patient's volume status, their glycemic status, and can they poop and can they pee. Those are kind of the 6 things that I'm thinking about. Now, I'm not going to get into the indications of dialysis for this episode. I mainly want to focus on the interventions that we hospitalists do on the floor for our patients. So essentially, you've got 3 ways to lower serum potassium. You can have them pee it out, you can have them poop it out, or you can temporarily shove it inside the cells. Okay, so let's talk about this for a little bit. Now, our urinary and fecal excretion are the only 2 definitive ways to have potassium leave the body. Whereas on the other hand, our cell shifters like insulin, albuterol, epinephrine, these are just temporary fixes. Okay? These are just band-aids, and you definitely want to consider them when you have an urgent case of hyperkalemia. You can't just order the albuterol and then forget about it though, because the hyperkalemia is going to come back. So let's talk a little bit about these individually. So Lasix is up first. Now I'm not going to get into the mechanism by which Lasix produces more urine output. Though the key thing here is that Lasix acts on this NK CL2 channel, and it blocks that channel. And one of the downstream effects of that is there's less potassium that's transferred from the tubular side of the loop of Henle to the interstitial side, i.e. it remains in the tubules and it's peed out. Okay, so by blocking that channel, you're not reabsorbing as much potassium and you pee it out. Now, of course, Lasix is only going to work in patients who can urinate, and it's obviously helpful if your hyperkalemic patient is also hypervolemic. Lasix is a great tool of choice, though in certain situations, if your potassium's persistently high and a patient is euvolemic, there's no reason you can't give them Lasix and fluids at the same time for this particular scenario. Okay, so next is our GI binders or Lokelma. Now, whereas loop diuretics increase urinary excretion of potassium, Lokelma increases fecal excretion, and it does that by preferentially binding to the free potassium within the lumen of the GI tract. So patients swallow Lokelma, it's not absorbed throughout the entire GI tract. The drug itself never gets absorbed, but while it's in there, it's soaking up all of this extra potassium, and then you poop it out and there's less potassium absorbed in the GI tract. You want to avoid this in patients with small bowel obstructions or other significant GI diagnoses. And just as a tidbit, if Lokelma is available, which it is at UAB, there's virtually no reason to ever use Kxalate. Okay, so they work very similarly. The mechanism of action is virtually identical, but the side effect profile is much better in Lokelma than Kxalate. So as long as you're at UAB, you shouldn't ever order Kxalate. Okay, so let's talk briefly about the cell shifters. So again, insulin and albuterol will shift potassium into the cells, though this effect only lasts for a couple of hours. When it comes to insulin, just like with our diuretics, if a patient's euvolemic, you can give fluids with it. If a patient is euglycemic, you can give, or often should give, dextrose with the insulin. And the thing to know about albuterol is that it takes very large doses to have a measurable effect on serum potassium, typically up to 20 milligrams of albuterol. Just for some context, when we order an AA neb for our respiratory patients, there's only 2.5 milligrams of albuterol in those nebulizers, so a much larger dose than what you typically administer. All right, so let's talk about my approach and how I think about hyperkalemia. There's always exceptions, but generally this is how I approach it. Now, a little disclaimer here, this is my personal preference. If you're an APP or a resident and you have some attendings that may get upset if you don't treat that potassium with 5.3, then do what you need to do, but those attendings would be wrong. So everybody has different thresholds. I just want to give you some context. So generally, especially if it's acute, I'm not going to be treating a potassium less than 5.5. Now, if a CKD patient has chronic hyperkalemia in the 5.3, 5.4 range, maybe I'll address it. But in the acute scenario, almost always, I do not treat a K if it's below 5.5. Now, if your potassium is between 5.5 and 6.5, that's usually when I'm going to think about addressing it. And then lastly, know that you don't generally get myocardial instability until your potassium is above 6.5. And obviously in those situations is when you should get really excited. Okay, so here's my approach. The first question I ask is it an emergency? So if your potassium is above 6.5, if you see EKG changes, if the patient is symptomatic with muscle weakness or paralysis, then it's an emergency. And in those cases, you have to administer calcium. Now, calcium will help stabilize the myocardium and significantly reduce the risk of developing an arrhythmia. The thing to know about calcium is that you don't just give it once and forget about it. You have to continue to give calcium gluconate until the EKG normalizes. Okay. These are the situations in which you consider emergent hemodialysis. Now, for the most part, critically elevated potassiums often occur in patients who are end-stage renal disease patients, and so you definitely want to dialyze those patients, especially since they often can't pee. Again, in emergent situations, I'm going to give insulin and dextrose just to get it down quickly. I'm going to give Lokelma if there's no contraindications. If my patient can pee, I'm going to give them Lasix, though again, often you're facing this in renal patients. And then consider albuterol. I don't use this a ton, but you need to think about it in somebody who's critically ill. Now, on the other hand, if it's not an emergency and you don't have to get the potassium down urgently, Lokelma is usually where I start, along with Lasix if the patient can pee. Obviously, you want to take into consideration the clinical setting. If the patient's hypervolemic, you definitely want to start with Lasix instead of making somebody have diarrhea. If they're hyperglycemic, address that with insulin. But in general, this is how I think about it. The other thing that you need to do is review medication. So if a patient's on an ACE inhibitor or an ARB or an ARNI or NSAIDs, we may need to stop those. And in more chronic situations, you do need to think about dietary restriction. Now, in a healthy patient, it's really hard to consume enough potassium orally to significantly affect serum potassium levels, but in your CKD patients, this is something you need to be thinking about. All right, that's all I got. If you guys have any questions, let me know. Thanks for watching.